Hello everyone, thank you so much for joining us today for this recorded update on the Medicare telehealth guidelines that were updated on March 30th. Those of you who joined us on March 26th for the new telehealth guidelines webinar, another release has come out from CMS on March 30th. So that's why we're doing this update today on April 3rd. So once again, my name is Rosemeen Babbitt. I am the President and CEO of CodeRight Healthcare Consulting. I just wanted to let you guys know what today's agenda is. Intro mine and my companies, which is going to be very brief if you were on the webinar last week. What has changed since the last release? So we're going to go over some new codes, some new guidelines that have been added on March 30th. New services added, coding and reimbursement. There are no changes on some of them, so we'll go over that as well. Virtual check-in changes, telephone calls, incident to guide. So once again, my name is Rosemeen Babbitt. I am the founder and CEO of CodeRight Healthcare Consulting. I'm a certified coder and auditor. I've been in the industry for about 15 years now and rose from the trenches, done everything from front desk to billing to practice management. And now I have my own company, which was established in 2015. We're based in Allen, Texas. We do medical billing, coding, and compliance for small to medium medical practices. And what's different about us is that we do not outsource any of our services. Everything is done here in the US. So your data is compliant and you have easy access to us. All right, so what has changed since the last release? So this release was on March 30th, 2020. It is called the Interim Final Rule for Telehealth Services by CMS. This is a 221-page document. Yeah, that's a lot of reading. So I have included the link here so you can access the whole document. Makes for some great bedtime reading. So changes are effective March 1st, 2020 instead of March 6th as previously advised. So that has definitely changed. So you can now bill telehealth services beginning on date of service of March 1st if you did provide that service at that time. Place of service requirement has changed. You do not use place of service 02 anymore for the place of service. Use the place of service that would have been used if the patient has been seen face to face. So let me give you an example. So if the physician is in the office and patient was supposed to come to the office and they're in their home because they're not able to come anymore and the telehealth services are being provided to them, then you would bill a place of service of 11. The reason that CMS is doing that is because they're realizing that the 02 place of service telehealth was split into two different into two categories. So it's because there was an originating site restriction before. So what they were doing is that they were paying a portion to the physician who's at a distant site, and they were also paying a facility fee to the originating site. So they were kind of taking that into consideration. So this actually probably what happened was this actually resulted in a lower payment. So this will add about $20 to the payment if you bill for the place of service where the patient is. So let's say if patient is in a nursing home, you would bill the place of service for the nursing home. If the patient is in the inpatient hospital, you would bill a place of service of 21 or 22 depending on either they are inpatient or on observation status. So I hope that makes it a little bit clear right now that you do not use the place of service 02 and you use the place of service that the patient is at. So if they're in their own home, you would use the place of service of 11 because they would have been seen in the office. Okay? So for office visit bill place of service 11, it's a higher reimbursement, as I just explained to you, that it's not a split bill anymore. It's just everything is being given to the provider who's providing the service. Now, okay, this is new also. So you have to use modifier 95. Before, Medicare said no modifier was needed, but now they're saying that modifier 95 is required. So place of service requirement has changed, number one, and modifier 95 needs to be used. That's number two. Okay. All right, so let's move on. So new services added, ED services have been added. So before there were different codes for you to see patients in ED and hospital inpatient. Now they have actually added the actual CPT codes that you would use in these locations. So ED codes 99281 to 99285. I don't know why my slides are going backwards, but okay. Initial and subsequent observation and observation discharge and day management. These are codes in the category of 99217 to 99220, and then 99224 to 99226, 9934 to 9936. Those are discharge services, discharge day management. Then inpatient visits, you would bill 99221 to 99223. And you would bill the discharge service for an inpatient 99238 to 992. So those are some of the codes, some of the examples that I have given you. I'm not going to go through every single code category. You can refer to the document that I have shared the link with you of, and you can kind of go through what is applicable to you. If you are providing services in skilled nursing facility, domiciliary care, if you guys are doing providing service in a hospice, you can go and look for those codes in that document. I just wanted to keep it very brief today, just to go over the recent changes. You can also refer to my previous presentation if you had requested an email of it. I've sent it to you. Look at, you can compare to what's changed and what's the same. Okay, so new services added again. Initial nursing facility and nursing facility discharge day management. These are the codes. Same thing here. Critical care services. So critical care services are provided in the hospital. So where the patient is, if they're as inpatient, then you would bill a 21 place of service to provide these critical care services. Domiciliary, rest home, custodial care, the new patient codes, and then the established patient codes. Again, new services that are added are inpatient, neonatal, and pediatric critical care and intensive care codes. So same codes that are actually used for these services will be used to provide the telehealth, but the new thing is that you will actually bill a 95 modifier. Group psychotherapy, end-stage renal disease services, psychological and neuropsychological testing. Now, these are all for new and established patients. Even though some of these codes actually tell you that these services are for established patients only, but Medicare has waived that restriction, and it's available for new and established patients now. Subsequent inpatient telehealth may be performed daily without the prior limit of once every 3 days. So that restriction has been removed or lifted. I must stress here that these are all temporary changes. So when the government declared a public health emergency, they declared it for a time. We don't have an end date yet, but when that end date comes through, when everything goes back to normal, all these provisions will go away. So this is temporary. Please don't get complacent and just think that this is going to be the norm for now. It's not going to be, because these are all temporary provisions that have been put in place to help the public stay home and still get the treatment and that they need, still have access to their physicians, still have access to the therapy that they were used to and that they were getting. So there are no gaps. And then, of course, we are also protecting our healthcare workers who may be visible to all these who may be at risk to get this COVID infection. So we are also protecting our healthcare providers and doctors. So these rules are put in place just during the public health emergency for COVID-19. Coding and reimbursement. No changes that I saw on this. Telehealth is still audio and video. So Skype, FaceTime, Zoom are okay because even though they're not HIPAA compliant, HIPAA has been waived for the public health emergency. So that has not changed. Telehealth service is still defined as asynchronous audio-video technology. It's still initiated by the patient, new or established patient, 99201, 99215. Somebody asked me about, to elaborate more on the initiated by patient. I did cover that in my last presentation, but I will tell you again that it is initiated by the patient, meaning the patient is calling the office to make an appointment, but they need to be told that this is a service that is available to them, that they can be seen by their provider, by their doctor in their own home. So this is what it means that, at least the patient needs to know that you are providing telemedicine. I've shared with you that physicians are posting it on their Facebook page, that they're providing telemedicine services, and they are also emailing their patients on their portal and sending secure emails to their patients and letting them know that they do provide telemedicine services. Reimbursed at the same rate as an in-person office visit. Must maintain documentation, same as an in-person visit. Verbal consent is required. That's not changed again. And then providers have the option to waive cost sharing. Okay. So there has been some changes in the virtual check-in requirement. So this is the brief initial communication with a healthcare practitioner. This is the G code that we talked about, the G2012, which pays very minimum. It's $14.31. And it is, so before it used to be for established patients. Now it's actually that provision has been waived as well. It's for new and established patients both. Verbal consent is required, must be obtained annually, and may be obtained at the same time that service is furnished. So what this means is that you don't, if you're providing this service on a regular basis, then you don't have to get a consent every single time. You can get a consent one time for the year annually, and then you can keep that on file. But you can also actually get this on every single visit as well. You can say, okay, we need to get this consent at every single visit, but that has been waived also, that you can actually have the consent on file. And then consent may be documented by the auxiliary staff under general supervision. So if the front desk person or the clinical staff is getting the consent and documenting that in the medical record, and the physician sees that and verifies that has been done, that is also okay. What's not changed is that no office visit within the previous 7 days and does not lead to an office visit in the next 24 hours. So that has not changed. That has stayed the same. And okay, so this is new right now. Telephone calls. So a lot of practitioners and a lot of facilities did go to CMS, and they said that a lot of their elderly population do not have audio and video technology. So would CMS cover telephone calls? So then CMS responded by saying that they will cover telephone calls during the public health emergency of COVID-19. So these are some of the rules here. So this was a previously non-covered service, but now it is covered. It's expanded benefits during COVID-19. It's about $13 to $39 depending on which code you use. Physicians, nurse practitioners, and physician assistants can use this code. There is separate codes for physical therapists, occupational therapists, and I think I added that in my last presentation. I did not add it here. Use the place of service 11. This is not a telehealth service. So for a service to be qualified as a telehealth service, it has to be audio and video. Since this is not an audio and video technology, it cannot be billed as a telehealth service. So you cannot bill your traditional codes, your office visit codes 99201 through 99215. You have to use the codes that are down here that are described below. This is also for new and established patients. So this is new as well. It's there needs to be no prior relationship between the physician and the patient. So that is also something new to keep in mind. And this is the next line that I have. The services may not be provided within the past 7 days or result in the visit in the next 24 hours. This is the same as that G2012 code, but this is more of an expansion of this code. Before these codes were applicable as e-visit codes, but now these are also okay with using just the regular phone and just doing an audio call. So I actually went on Novitas's portal this morning. Novitas is the MAC for Medicare here in Texas. And I plugged in these codes and they didn't have any fee schedule updated for it. But I did find from another source the range, the $13 to $39 range. I'm pretty sure that it's very, very similar to what Novitas will have. But right now, as of today, this morning, those codes were not fed into the fee schedule. So 99441 is a telephone call for 5 to 10 minutes. You have your 99442 is a telephone call for 11 to 20 minutes. And you have your 99443, a telephone call for between 21 and 30 minutes. Somebody did ask me last time, how long could a telephone call be, like a virtual check-in? And I told them that, that G2012 code was just that one code and it was paying like $14. So since Medicare was requested by practitioners that was very minimum, and because a lot of people didn't have telehealth services, that they kind of found this medium ground, I believe, between doing it between actually providing a telehealth service, which of course pays more, like the office visit, or doing just a brief check-in, virtual check-in, which was just paying about $14. So this is a little bit of a middle ground, I would say, between those two. Okay. All right. So also want to share the Incident 2 guidelines. There are a lot of physicians who have nurse practitioners and physician assistants that do work under them, and they are the supervising physicians. So the original Incident 2 guideline was that in order to bill a service, it's Incident 2, if the physician supervisor needs to be present in the office suite, not necessarily in the room, and must be immediately available to furnish assistance. So this is the current guideline that's in place. So it's not something that has been thrown out. It's still the current guideline, but it has been modified or has been expanded for the public health emergency COVID-19. So this reads as: necessary presence of the physician for direct supervision includes virtual presence through audio, video, real-time communication technology when use of such technology is indicated to reduce exposure risks to the beneficiary or healthcare provider. So let me explain this to you a little bit. So let's say the nurse practitioner is seeing patients via telehealth, and he or she is in the office. He or she is in the office and providing this service from the office. But the physician who is the supervisor who supervises the nurse practitioner or the bills under his tax ID is not in the office. He or she is actually in their own home. So that can actually, they can both call in to the same encounter. So if the patient is being called for a telehealth visit, like let's say Zoom, you can have a Zoom meeting with 3 people on it. you can have a FaceTime visit, I believe, with multiple people. I'm not sure how that works, but I know that Zoom meeting does, and I know that there are providers who are using Zoom, and I think Zoom probably is the best option for this. So a nurse practitioner is in her office, the provider is in his home or his or her home, and the patient is in their home, and they can all be on the call at the same time, and that service can be billed under the physician because he was there as a direct, he was providing direct supervision, even though he was not physically in the same location as the nurse practitioner. Another thing that I didn't put on here was that a lot of physicians have closed their practice. So if they're not, because they don't have a lot of inflow of patients, they have closed their physical practice location, and they are providing these services from their own home. So that can be used as a distance site. So physicians' home can be used as a distance site with a place of service of 11. So what's changed with commercial payers? Like I said last time, all commercial payers make up their own policies and procedures. So please, please, please make sure that you go to your specific plan, policy, whatever, and verify this information, because this information can change from state to state. It can also change from a patient's plan. So if you're just seeing patients on telehealth and saying, oh, okay, this applies to everyone, it does not. The patient who has like a small generic insurance, they may not have telehealth benefits. You can't just assume that patients have telehealth benefits, you know. A lot of these big companies like Blue Cross and United Healthcare have followed in Medicare's footsteps and said, okay, we are going to expand these benefits to our beneficiaries, but not every insurance company is going to be doing that. It's not a blanket rule because, you know, they're for profit and they make their own rules. So you want to definitely make sure that you go on their site, or better yet, when a patient is trying to make that appointment, you are calling that insurance company and verifying their benefits and asking the rep that, hey, are telemedicine benefits available? And then providing that service to the patient if they want to be covered under their insurance. So let's see, Blue Cross Blue Shield has updated their policy on April 1st. And I checked these this morning, and I've updated the links as well, so you can follow those links if you need to. The telehealth service expanded effective March 10th, which is the same, I believe. Audio-only services may be covered. So this document that I have linked down here has all the codes in there that are covered. So I believe there are some audio codes in there too, but you have to make sure that you are following all the regulations, that if, you know, the telehealth services are not available, then you are, if you're using the telephone for audio only, then you're following all the guidelines of consent and whatnot. And what is new here is no member cost sharing for covered medically necessary services and behavioral health services. So this is new. This is last time they said that patients will be required to pay their co-insurance or co-pays or deductibles, but now they're saying that there's no cost sharing. So that's actually very good news, and I'm thinking that they may then cover it as a whole, like whatever their allowed amount is, they will pay all of it, regardless of patients' out of pocket. I'm not sure how that's going to work, but this is what they are saying. I have seen some claims getting paid that we have billed for some of our clients, and they are getting paid as they would if it was the service was provided in the office. I haven't seen any Medicare claims paid yet, so I can't speak to that. But I know that there was a Blue Cross Blue Shield claim that was paid, and I felt that the reimbursement was the same, and actually had sent that as and that for Blue Cross United, all the commercial payers, your place of service remains the same. It's 02. So please don't change that for your commercial insurance. Do change that for Medicare. Medicare, you need to change the place of service to wherever the patient is, but don't change that for Blue Cross Blue Shield, United, or any other commercial insurances unless they have specified to you to do that, which they have not. They have still maintained that you use the place of service of 02 for telehealth and you append the 95 modifier. Now that's actually applicable across the board. Even Medicare is asking you to do that. For United Healthcare, they updated their policy on March 30th. And they're saying that effective March 31st, 2020 through June 18, they're also waiving the cost sharing for in-network telehealth services. So that's good news for patients. And I hope that they pay the providers the full amount that the provider needs to provide these services. But it's good news for the patients because, you know, a lot of patients are struggling right now with unemployment and being furloughed. And, you know, our hearts do go out to all of them. And I also wanted to just mention that, you know, all the healthcare providers and, you know, who are in the front lines, huge thank you to all of them. To all of you who are on this webinar and who are in that support role, whether you're you know, biller, coder, office manager, your clinical staff. Thank you to everybody. Also wanted to say that everybody just follow the guidelines that, you know, everybody that the government has put in place. I hope that we do beat this thing sooner than later. So that was my thing for today. As I said last time also, this is a constantly evolving situation, and I was not wrong. We just did a webinar on March 26th, and they came out with all this new stuff on March 30th. So and it's not to say that, you know, that's it. I think there's going to be more information coming out, and we will try our best to keep you updated. I may do another live webinar, or we may do another one of these recorded ones that you can access on demand. And then stay connected. CMS, all your websites, your coding associations, if you are part of, you know, auditing associations, whatever, you know, associations that are dealing with billing and coding, please stay connected with all of them. Make sure that you are looking at the latest information. Physicians also get a lot of information from AMA, so do pay attention to all these regulations and guidelines. Right now, of course, they're all in effect, but we also have to think about the end date for this as well. So we want to make sure that if we are getting seeing patients and we have claims, so then we get them filed as quickly as possible so we can get paid as quickly as possible. So that's it. For any questions, you do email me, and I will try to answer as many questions as I can. I may not know all the answers. We typically deal with physician offices on an outpatient setting, so I may not know a lot of information about inpatient and skilled nursing facilities or long-term care facilities. I have gotten some questions about that, and I do apologize. I don't know those. So you might want to ask that to somebody who knows that information, who is directly involved with coding for those facilities. If you direct a question to me, I will try my best to direct you to a resource that may be more helpful than I would be. But I try to stay updated as much as I can on the things that are relevant to us and the clients that we serve. So please stay connected. Follow our Facebook page, Code Right Healthcare Consulting. You can connect with me on LinkedIn and subscribe to our YouTube channel. We do post a lot of videos. Haven't done that lately, but we will soon again. All kinds of stuff for practice management and compliance and policies and procedures and billing and coding and all of it related to all of that. So once again, thank you guys. Thank you very much for listening in today. And hopefully, I hope that all of you will stay safe and stay home and take care. Bye.